we all agreed that those are the three mechanisms: trauma, right? Insidious onset pain or altered motor control. And then he said, are you good at diagnosing altered motor control before it's a problem? And I said, no, that's the problem. And he's like, so he goes, you need to understand though, he goes, I'm not even sure if we know what normal is, but we need to know what normal is before we can identify abnormal. But we all know this is probably the leading cause of musculoskeletal pain, is some type of altered motor pattern is happening before the trauma or the injury is happening. And he said, this is going to be a tough journey. This is what Liam said to us. And we all, in our young, cocky stage, said, hey, I think enough smart minds around us, I think we could knock this out in 6 months. Well, that was 2005.
You kids are soft. You lack discipline.
We landed on the moon!
You didn't earn the knowledge for yourselves, so you don't take any responsibility.
It's like we've forgotten who we are. Explorers, pioneers.
I wanted to jump off on, because I think it's going to set up the rest of the conversation, was you brought up again, which I've heard you talk about, I've known about for a long time, is the alternating joint hypothesis, which Mike Boyle, Greg Cook of, mobile, stable joints. My question is, and I don't want this to be like, hey, we say different stuff when we're in different crowds talk. That's not what I'm trying to get after here. But is that a rule or is that a heuristic? And what I mean by that is it something you live and die by, or is it something it's like, hey, when you're kind of new and you're learning things, it's a good rule of thumb? Or if we had different level of professionals, it plays better for, maybe the coach versus the medical professional, just because we operate at different levels of information. Like we're all just, operate at different levels. What's your take on that?
Yeah, so this is a loaded topic, but I would say that this is our 99% rule, right? So I would say nothing's 100%, right? But like you said, I think this is a very gross oversimplification to understand how the body would prefer to move, let's put it that way, or was designed to move. And we always say that, certain joints were designed to be very mobile. Those are the joints like the ankle, the hip, the shoulder, the thoracic spine, the wrist. Because if you look at the joint angles and you look at the orientations and you look at basically the design of the joint, it's meant to move in all three planes pretty freely, right? So, like your ankle can move in every direction, your wrist can move in every direction. But then there are certain joints that are designed to move in one plane of motion, right? Like your lumbar spine. I would say lumbar spine, it better be mobile. Like you better be able to move your lumbar spine. Now, in our joint by joint approach, we call it a stable joint, right? What that means is that it's very mobile in one direction. I think a lot of people think stable joint, well, and they just go, oh, that doesn't move.
Right.
The world I'd want is your lumbar spine not to move, right? But what we want the lumbar spine to do is move in the axis that it was designed to move in, right? So it was designed to flex and extend. When you try to twist and side bend from your lumbar spine, a lot of bad stuff happens, right? So I think basically, the number one thing they argue about, like, should that be stable? Should that be mobile? Every joint in your body is mobile. That's why they call it a joint, right? It's supposed to move. Our philosophy is more of three-plane versus one-plane joints, right?
Okay.
And so what we say, and when you think of it that way, it's pretty much the 99% rule, right? It's kind of like, all right, your knee was primarily designed to flex and extend. Can it rotate? Yeah, it can get up to almost 20 degrees, depending on if the knee's flexed or extended. And can it side bend? Yeah, but do I really want it to side bend? Probably not. You know what I mean? So I think in my way of thinking about this is I always try and make the path of least resistance through your mobile joints. If your mobile joints are restricted, the body tries to take the path of least resistance. Well, a restricted mobile joint is not the path of least resistance, so it tries to go through a stable joint. When a stable joint tries to become a mobile joint, which it can, 100%, we tend to get bad stuff happen.
Yeah. Well, and I bring that up because, again, you're creating it's almost like creating a recipe with treatment. You create some sort of schema so people can better understand how something works that's extremely complex, because it gets argued. You see it in social media and all over the place, that this whole, I don't know how long this concept's been around, that people are like, well, every joint's supposed to be mobile, and then it gets kind of misconstrued or taken out of context.
I think this is that word stable. Like when we say mobile, stable, and I think when they use that word stable, I think people might think of that as immobile.
Yeah. Well, it
That,
gets into the neutral spine, misrepresentation and things like that. That
yeah.
again, I'm not saying like you and I are on the same team, like, oh, we're against all those other people and we know what we're talking about. But the misconstruing, I think, literally just comes down to people wanting to argue. I think if you literally sat down in the same room, we'd be saying the same stuff.
Sorry, I got my doctor. But I actually think it's terminology is first and foremost. I think when people we
Yeah.
really sit down and listen to them, you kind of go, well, wait a minute, you're saying the same thing I'm saying. They just don't realize it. And then sometimes I think they start arguing over is what's more important, strength training or stretching. And if I'm going like strength training versus stretching is not the mobile stable conversation. Those are two totally different
Right.
conversations, right? Like if I want to improve your mobility, I can use strength training, right?
Mhm.
That's we're not talking about like what's more important, stretching or strength training. I see a lot of people confuse that, and I'm like, well, you're not even speaking about the same conversation topic, right?
Well, in a way, do you feel like, because a lot of what you and Gray Cook and the whole FMS, SFMA kind of team have done is tried to simplify things, right? Create screens, create assessments. And sometimes I think the simplification actually gets a lot of pushback because it seems oversimplified. And then people are like, well, that's not how it is. And you're like, yeah, we know. That's
Yeah. Yeah, well, I think, it's kind of like I believe everybody prefers, this is just my personal bias, to be talked to like third grade, right? So I don't want to be talked like I'm an idiot, but I just want please make it simple. Like don't like the MRI is for the doctor. You don't hand the MRI to the patient and go, here you
right.
go. You look at it, you've got had a lot of education to read it, and then you try and explain to them in third grade what's going on. It's the same thing here, and I feel like people sometimes are like, "Man, your screen is it's so basic. Like, there's so many more." And we're like, "It's not basic enough. Like, we're trying to make it simple, right?
Yeah,
Simple."
which it is important. And again, I think I was telling people in the crowd while I was listening to your talk of, why I thought you were such a good teacher is how, analogies, stories, and simplification for the purpose of understanding, not just to dumb it down.
Yeah.
Uh, but that's tough. I mean, you're literally taking the most complex thing in the known world, the human, and trying to like make it more understandable within the realm of, a professional setting. Um, Something else that you brought up during that talk was you talked about and I don't want to, I'll let you tee this up, but you talked about the three pathways in injury, right? And I think you brought up a coach from, what was it,
Ireland.
soccer? Or yeah, or
Yeah. Liam Hennessy,
yeah,
one of the best physical therapists on the planet. Yeah. Um, yeah. So, when we were doing our advisory board at TPI, right, we have advisory boards so that Titleist, we have advisory boards for coaches, we have advisory boards for fitness professionals, and we have a medical advisory board. And when we got that medical advisory board, me being young and naive, I said, I want to make a difference like everybody does, right? And I want to do something special here. And I remember saying to Gray at the time, Gray Cook was on that board along with a bunch of other smart men and women, and I said, hey, you got your functional movement screen, right? That's for healthy people. I go, but you always say, if someone's in pain, it can alter the FMS, and it's really not designed for people in pain. I'm like, we should create a pain one, right? And he said to me, I always say, I felt like I was talking to Henry Ford. He was like, actually, I've been actually working on one, and I always say he showed me the backbone of the SFMA. Like we got in the car, we drove, and I'm like, this is amazing. Now, halfway down the road, the tires fell off and the engine blew up. But I was like, that's a cool idea, but it needs some work. So we went and basically made it our journey to let's perfect this screen. And I took a bunch of these smart men and women on the advisory board and I said, I want you guys to help us do this, right? And I said, I want to be able to come up with a movement screen that can predict injury, or predict the cause of injury, right, better than any other movement screen on the planet. Because I always say, there's source and cause, right? So if your knee hurts, that's the source of pain, but the cause could be your neck, right? It could be anything. So we're like, could we come up with a movement screen that could identify the true cause of the source of your pain? And this very smart man, Liam Hennessy, said to all of us, he said, Greg, if you're gonna come up with a movement screen and you want it to be the best on the planet, you really need to understand the mechanism of injuries that can happen. And I'm like, well, I think we're pretty good at that. And he said, I don't think you are. And I go, what do you mean? And he goes, I think this is the problem in medicine. And this is probably 2005, maybe.
Mhm.
He goes, Greg, I think we can put all injuries into three buckets. He goes, the first bucket would be trauma, right? So obviously, if somebody punches me in the face, I know where the injury came from. It was a fist hitting me in the face. And he said, "Are you good at diagnosing a trauma?" I said, "Yeah." So if somebody gets a trauma, I can see where the swelling, the pain is, right? Let's say you twist your ankle swells, so the trauma creates the pain, and then I could see how they alter the way they walk because the injury created the altered movement. And he said, "I agree with you. I think you guys are good at trauma." He goes, "Okay, there's a second way to get injured. The second way to get injured is insidious onset pain." He goes, "What if you didn't sprain your ankle, but you just start walking and your ankle had pain?" I think we've all experienced this. Insidious onset pain, right? I don't know why it hurts. I don't remember doing anything, but it just hurts, right? Now, he said, "Are you good at diagnosing insidious onset pain?" And I was like, "Well, it's not as easy as trauma, right?" But I was like, I can track dermatomes. I can evaluate the joint. I think I can still figure out why the joint's hurting. I go, when you get insidious onset pain, it alters the way you move. I understand why you're moving weird. And then, because you're moving weird, it can lead to bigger traumas because you're not used to walking this way. And I go, so related, but yes, I think we can diagnose that. He said, good. He goes, now there's a third category of all musculoskeletal injuries. And he said, that's basically altered motor control. He goes, in other words, have you ever woken up where you just weren't walking the same, right? Maybe you slept on a different bed, you ate some different food, maybe you worked out in a gym that you haven't been out before. And I said, we've all experienced that too. Let's say you're traveling and you get up and you're just like, man, I just feel stiff today, right? So now when you feel altered, you don't usually do nothing. You usually just walk it off, right? You alter the way you move. So this altered motor control it's altering the way I move. So I'm moving weird. Because I'm moving weird, I'm vulnerable because I'm not used to doing this. And that can create trauma, which can create pain. And we all agree that those are the three mechanisms: trauma, right? Insidious onset pain, or altered motor control. And then he said, are you good at diagnosing altered motor control before it's a problem? And I said, no, that's the problem. And he's like, so he goes, you need to understand though, he goes, I'm not even sure if we know what normal is. So we need to know what normal is before we can identify abnormal. But we all know this is probably the leading cause of musculoskeletal pain. If some type of altered motor pattern is happening before the trauma or the injury is happening. And he said, this is going to be a tough journey. This is what Liam said to us. And we all, in our young, cocky stage, said, hey, I think enough smart minds around this. I think we could knock this out in 6 months. Well, that was 2005. I will tell you that we're, virtually almost 20 years into this, and we're still not done, by the way. But the SFMA has come a long way, and it's pretty impressive. But our whole goal was to try and do what Liam said: become the best at identifying altered motor control, because we know it's probably the number one cause of musculoskeletal injury.
Well, and that was, you and I didn't, we went to the dinner, that Saturday that we were in Florida, and I was kind of giving you the 50-cent version of what I was going to talk about on Sunday. But this was kind of, this is a question. This isn't, an answer or anything, but as more research has come out, and in particular, people like Phil Snell and Justin Dean have started kind of elucidating some of this. And, this goes back to Diane Jacobs. And people have been talking about this forever. There's the three mechanisms. Trauma, let's remove that. We get that one for sure. Obviously, I don't want to put words in your mouth, but I think you just said it. Like the SFMA and that tool is very much focused on altered motor control. We go after the dysfunctional non-painfuls and try to let things change, right? Permeate through as we focus on those. My kind of what I was bringing to topic was, there's a lot of evidence showing that sensitization in the periphery can occur without altered motor control. It can just happen with normal movements, right? Without aberrations. And then we could get into the whole, are there bad biomechanics and good biomechanics, which I think I kind of know where you'd lean on that one. But then that leads to the question of, well, there's two questions. Are there times when you're actually treating pain to not let the compensation, come through? And how do you pick that up in the screening process or the assessment process? Or like, hey, I think this is insidious onset pain, and we know that will change motor control or alter motor output. And then the other one is, well, how often is that happening? And like you said, the SFMA mindset is, hey, we think altered motor control is driving the majority of the pain that we're seeing outside of trauma. And again, I don't know. I'm just looking at both sides.
Let me just say real quick. Well, I believe in all three categories, right?
Right.
So I do believe there is pain generation without altered motor control first, right? So, um, like I said, I think that's I don't think it's the most common, but it doesn't even matter. If we have the debate on like what's the most common, who cares? They're all three are possible. So you have to be
Right.
good at all three of them, right? You know what I mean? So I'm not sure if your question was, do I believe that there's like a
No, I guess
yeah,
because again, I agree that all three, and again, I think it would be hard to determine what is the biggest swath. But my thing is,
yeah.
if we have a really trauma, that's easy to pick up. We have an on-field assessment, right? Your sideline care. Alter motor control, you guys literally have built, in my opinion, the best tool for sussing that out. Well, then is it, hey, it's exclusionary criteria. You
It
went
could
through all this, and then this is what you're left with. Then is that how it's treated, or is there some other way? And that's kind of what I was presenting.
well,
And I was just presenting the evidence, not necessarily the best tool, because I don't know if there is a best tool.
here's what I'll say about it, and this is in no way the correct answer to your question, but you know, if you had somebody in pain and you did a top tier SFMA and it was clear,
Yeah.
right, everything red, then I would say alter motor control is not your source, right?
Yeah.
Well, or not your cause here, right? So I'd go. Now, with that said, it's very rare to see somebody who passes all those, but that doesn't mean they can't have both, too.
Right.
You know what I mean? And then it gets to that chicken or the egg. Like, if somebody came in, did it start with insidious and now they have alter motor control? Because
Right.
I don't know
Yeah.
what I them, you know, I have to got them after, right? So, you know, the question is how long can somebody have this desensitization or this pain pattern and not show altered patterns? I think you'd have to get them fresh. Like, I think
Yeah.
it
And
would.
I think it's almost immediate. I mean, look at an ankle sprain, and we know it's like literally
Yeah,
a
that's
student.
trauma. Yes, but I'm just saying like if you said, hey, what if there's a bunch of people who don't have altered motor control, but they have these problems with pain or air? I'm like, how long could they have those problems and not alter their motor
Yeah.
control? I don't know. I don't know if that exists. It sounds like a unicorn to me, but maybe you get them fresh.
Yeah.
You know what I mean?
Uh, well, that tees up this next part. So again, maybe it is just exclusionary. You're like, man, we've went through this. It doesn't fit the categories, and now
Yeah.
we're jumping over here. Uh, at this stage in your career, so you said 2005 was the first like kind of epiphany moment with the SFMA of Gray showing you that.
Yeah.
So almost 2 decades later, are you, if we walk in and I shadow you for a day, treating golf and stuff, is it just like the playbook of SFMA? Is it strict? You're running top tier to full breakouts? Or if we watch Greg Rose, like, how the hell did he get there? Because you're jumping around now because you're allowed to break the model.
Hey, Rob, if you're in the SFMA, I apologize now. I'm the jerk who made the flow charts, right? So I'm the engineer of the group. So I I like flow charts, and when I create those systems, I do not deviate, right?
Yeah.
So I just feel like I've you want to say experience allows you to jump, but experience can make you make a mistake by jumping
Agreed.
too, right?
Yeah.
So I think if somebody walks in first of all, if somebody comes into TPI, comes in to see me, if they have pain in any form or fashion, we're doing top tier SMA immediate and breakout,
Mhm.
right? Now, if they don't have pain, that's a different story. Then we're going a different route. But if they have pain, we're running the rule book. That's the way I do it. So some people are surprised. We have people shout at me all the time, and they're like, "Oh, I thought you do something totally different than you teach in your classes." I'm like, "No, we actually do
Which
exactly."
is refreshing. It's got to be, because I'm sure that exists out there within the teaching and seminar world. So I did ask you this question. We didn't get to talk on it too much. That if you get to the end of the SFMA, outside of a motor control issue like an SMCD or whatever the most current terminology is, you basically get down to like a tissue disorder, dysfunction, or a joint disorder, which comes down to hands-on palpation,
It's
which I
either
heard
you get mobility or stability, and if you got a mobility problem, it could be joint or tissue.
Yeah.
Yeah.
So for those, maybe students, new docs, even people that have been in practice for a while, there's I don't know how big a wave it can seem bigger than maybe it is due to social media, but there's a big wave of, hey, we can be totally hands off of treatment. We can do an assessment. We can go through load management protocols. So let's say somebody uses an SFMA and they get down to the area via breakout that they think there's a problem. How important is hands-on palpation? And then we could take that into actual manual therapy if that's necessitated based on exam.
Yeah, I mean, this is going to show my biases now, though. But I feel like that one of our weapons is our manual therapy skills, right? So I feel like I always I know we have rules on whether it's tissue or joint, but when I get my hands on it, I can kind of start to really tell,
Yeah.
and this is where experience comes in, like, oh no, that feels like the joint's restricted, or no, that feels actually like more tissue. And I feel like I always say mobility problems are like brick walls, right? You want to knock down that brick wall. Now, exercise can be a hammer and chisel, and you can knock that wall down, but sometimes you're like, just give me some TNT, right? That's manual therapy. That's what we do, right? So I'm like, if I can just blow the wall down in one visit and then have the exercises keep the wall down, I'm going speed. I just feel like clients, as we all know, humans want the easy button, right? I mean, if this is why people take medications and pills, and so they just want the easy button. And I'm going, you know, uh, I'm pretty much the easy button. You're the easy button. If you lay down on my table, I don't know how much easier that gets, right? We can kind of knock this loose. Now, I always say you can't be lazy. You're gonna have to try and keep that wall down, and I'll show you the drills and stuff to do that. And if I can't get the whole wall down, you're gonna have to help me with these exercises to perpetuate this. So a lot of times it's a teamwork approach, but no, there's nothing wrong. Like if you're not licensed to do manual therapy, hammer and chisel works too. Like let's let's keep going. Let's knock the thing down. And there are some amazing exercises. Now, I'd say with a little caveat, this is why SFMA differentiates mobility from stability. If it's an SMCD or stability problem, well, I don't know what to mobilize. There's no
Right.
definition. There is no mobility problem.
So like you guys going back to the whiteboard ever, have you ever thought about going further into helping people determine, joint versus tissue just beyond, because I mean, when I got taught the class, maybe it's different now. I mean, you guys were like, well, you got to figure that out with hands. Have you went further?
Yeah, in our level 2 SFMA, we have an entire diagnostic algorithm now where we go through and we try and give you the signs differentiating. Like, I'll give you a couple. So the big signs we would say between tissue and joint. So joints tend to be, I call it equal opportunity employers. They restrict multiple planes, right? So if a joint's restricted, let's say your hip flexion is restricted, but everything else is clear. I'm not saying that can't be joint, but that more thought that there's a higher chance it's tissue. Whereas hip flexion is restricted, hip internal rotation is restricted, and hip extension is restricted, I'm starting to lean more towards the joint. It's probably restricted. So joints tend to go multiple planes. Tissue tends to go single plane, but once again, I can tell you tissue that restricts multiple planes. So you got to get a nerve palpate. And then the second most obvious would be when you're taking a joint, like if I'm flexing my elbow, right? Where you feel the tightness, right? If it's on the contractile side, there's not many tissues that get restricted on the contractile side. That's usually joint block. Or if it's on the elongating side, you feel something tightening up. That's usually not joint. That's usually more tissue, right? So if I feel something on the elongating side and only one plane of restriction, I'm pretty confident I'm dealing with a fascia or a tissue or some type of connective tissue. If I got multiple planes, it's on the contractile side, I'm going, it smells like joint to me, right? So we kind of go through, we show an accessory joint palpations. We always, if it's restricted, we always like to palpate joint first, because if the joint's not clear, it's kind of even hard to get to the tissue tension, right? So we do accessory planes. In our level 2 SMA, we teach our online classes and live classes how to do those palpations, and then we do a tissue evaluation that we really took from Mike Leahy at ART. I helped him teach the diagnostic track for ART, and it's a tissue palpation. Try and find where the links tension are. So yeah, we do I think we do now help you get to that local biomechanical testing.
Yeah, because you basically just left us out to fend off the wolves. Yeah, you're just like, better be good. No, I figured that was coming, but we were fairly early in the game. So now getting more, I'm interested in all this stuff, and now I have questions that I've literally had since I took SFMA almost a decade ago now. Obviously, the TPI, SFMA medical model has been wildly successful with golf and tennis and baseball, rotary sports. The SFMA and FMS are based on neurodevelopmental models. You talked about that a little bit in Florida. When we look at running, right, because I'm into running both from personal, what I like to do, but also who I treat, it's kind of at the top of the developmental model, right? Like nobody teaches you how to run, but for some reason there's a lot of gait training and gait retraining and all. So I'd love to pick your brain on, first of all, do you think that a model like a TPI model of screening specific for running as a sport could work?
Oh,
I know it's a broad question.
I have no doubt. I'm 1000%.
Okay. So here's my next question then. So I've thought about this for years. I actually put a pitch into Brooks about the Brooks Running Institute, trying to steal everything that you ever put out there and say, hey, there's this TPI thing.
Great.
And the pushback I kept getting from people in the field that work with running is, well, running is this thing that's not learned. And then there's two diverging paths, right? It's basically, if you looked at dynamic systems theory, right? You have attractor states and how a joint can move, or, what's allowed or not allowed is going to drive something. And then you have this whole gait retraining that you can see people, you can change, via cadence and stride length and all these, different mechanisms. I don't know how much you've worked with runners. I'm sure just from being a biomechanics nerd, you could dive into this, but I know where I stand. I just want to kind of hear what you think. If you think that model can work, you just said yes. Well, then do you think that we should be or could be coaching runners from a skill standpoint, just like a golfer? Because I asked the question during your talk of,
I can't even believe that's a question.
well, if you look at the research again, and you look at the highest level people in the field, there is not a concise, one side or the other. It's literally split in the middle.
That's crazy to me. So it's I can use this analogy anywhere. Like if I said, throwing is not trained, it's just something that humans can do,
Yeah.
right? Okay. But pitching, right, is a skill of throwing that is highly trained, right?
Mm-hmm.
So, I agree. Running, humans can run. That does not mean you're going to go beat Usain Bolt, right? That's a very highly trained sprint. Is a very highly trained. So, is that what we're talking about? Like running as a sport? Or are we talking about
both sprint and distance can get some different, ideologies. I get that, but yeah, just running as a sport. Yeah.
Yeah, so it's kind of like, I always feel like when you're young, you learn basic human movements, the fundamental movement skills, right? So throwing, running, sliding, hopping, all those things. And those have no there's no objective. It's just, throw that way, right?
Mm-hmm.
When you put it into the framework of this is a baseball game, you have to stand on a mound 60 feet 6 inches away. You have to hit into a certain zone over here, and you have to fool a hitter over there. It now becomes a fairly highly trained skill.
Mm.
And there's no way anybody's going to tell me that you can't train pitching, right? From throwing, right? Those are two different. Even if it was, I'm a hunter, I'm going to throw spears. There is an artwork that's passed down for generation on how to do these things, right? So to me, any movement, of course, your humans learn how to do these movements, but any movement can be turned into a sports skill, right? If you put the boundaries, the technique, there's rules, guidelines, anything that has that, now all of a sudden motor learning becomes an appropriate fit, right? And I've spent many hours watching coaches improve people's running. Just people, it's biomechanics is sometimes opposite of what you believe, what you think. You think, oh, I should do this, and until somebody really highly trained and skilled tries something new and different and learns something, until that information, because it's not intuitive, it's not natural, right, to pitch like that. If I said, and I guess different tracks, different terrain, change all these things. But to your question is running a skill. It depends on if this is a sport. If it's sprinting, the 200 meter, the hurdle, those are sports. Those are 1000% trained, right? Do I agree all humans can just learn how to run on their own? Yes. Will some be faster than others? Yes. They might get luckier. But if I train somebody how to sprint based on our biomechanical information, they'll beat all of them.
What about, does it change at all for distance running? Let's say we get a marathoner.
1000%. It's still a skill.
The reason I ask that is, so if you look again at dynamic systems theory applied to running, what they've seen, especially as they study more ultramarathoners, is people, they slip into this attractor state regardless of coaching. And they see this shifting that they've seen. Basically, they did a study at Western states where they just, put basically dartfish-esque technology on people and watch what happened to their gait, and they saw people gait shift. So they would go, to more pendular gait, kind of a double stride, so they're almost like speed walking to running, and they would do it normally to basically probably offload tissues and metabolically efficient. And then coaches took that data and started coaching people to basically gait shift throughout an ultramarathon to change their gait consciously. So you talked a lot about motor learning concepts in your talk, which that's where I wanted to go with this, because now it gets very interesting to me that, okay, for sure, I agree, we can coach the skill of running. But then you see the longer somebody runs based on metabolic demands and then also biomechanical efficiency, like what you can do for muscular endurance and how the joint moves, that people tend to fall back into the same old pattern, that old book, as you would say, right, at a certain distance. And then it gets really hard. Do you think that's, just another training like echelon they have to kind of work on, or like, do you think that's just like, God, that's a really hard thing to change, which I get it's hard to change. That's motor learning.
I guess what I'm trying to say is I would find it really hard to believe that if I took the top 3 ultra marathon runners in history and I put them in front of a young ultra marathoner that they couldn't teach anything.
Yeah.
You agree with that?
I agree. Yeah. And again, I agree, but again, there's no absolutes. I think we'd agree on that as well.
Yeah.
If you looked at the top,
Let me say something about genetics. Okay.
Yeah.
So, I always say we always say, working hard beats genetics when genetics doesn't work hard, right? But if genetics work hard, it's hard to beat, right?
Yeah.
So there are maybe some freaks who are just born with all the knowledge, all the wisdom of wherever they got it, and coaches just need to get out of their way, right? I am sure we can come up with examples of that, but I am also 1000% sure that is not the majority. That is the extreme minority. And I'm going, I don't know if I'd like, if I want my kid to win the Super Bowl as the quarterback. I don't know if I want to just go, I just hope they got the genetics where we've seen you can train a quarterback. You know what I mean?
Yeah.
Yeah.
Well,
Again,
I think
might be one of those, like you said, like, I don't want to be so naive to say, like, I can't imagine that you being the best at a sport, and to be the best in the sport, you just need nothing, just no previous information, no coaching, just keep people away from you and you win. I'd have to see a lot of evidence of that. You know what I mean?
the other interesting thing is when you look at the differences in people's gait based on anthropometric measures and male versus female and what sports they played growing up, what distance they ran growing up, and how they got into the sport of whether it's marathon, ultramarathon, the Olympic trials are going on right now. What I see in running is that it's not a TPI approach of there's a million swings for a million golfers. There's running gait, and then that has to permeate across. I think that's the problem, in my opinion, of how running is trained as a skill, is it's very put in a box. And I get that there's...
Well, let me tell you, I'm going to give you the secret sauce here, that this is, people always ask, like, so you said not a TPI model. Well, let me explain to you what a TPI model is, like how because we've done this for softball, we've done this for baseball, we've done this for tennis. Actually, I'm building one for quarterbacks right now with Jordan Palmer, and we've got I built one for U.S. lacrosse. We never launched it, but we got I feel like you can do this for any sport. Here's maybe the difference, and maybe you'll understand my philosophy. I believe that if you take any sport, let's take running, right, and you take the top 20 minds in biomechanics or coaching, you put them in a room, and I said, okay, guys, let's all agree on what's the best way to run. How's that going to go? Is that going to be smooth, or is that going to be like World War V?
In running, I'd say it'd be fairly smooth if you took the top 20.
So I'm talking about the top 20 coaches in the world. I'm talking about the top 20 coaches in the world. Coaches, not players, like the coaches, and say, can we all agree on this is the best way that you should run?
I think there'd be a little bit of strife, but I think largely everybody agrees.
Okay. Well, that would be very unique. Usually there's lots of different techniques and stuff like there. Normally,
how people train, I think, would be the point of conjecture and running.
Not even there yet. It's just more of agreeing on what running should look like, right? Normally, what we find, like I said, let's take 20 baseball pitching coaches, put over and say, okay, what's the best way to pitch? We're going to have a debate, right? They're going to have 100,000%, because you and I both know there's a million ways to pitch, right? So what they're all right and all wrong, right?
Right.
So what we never do is we never say, here's how you run. here's how you golf. Here's like, you'll never, you come to TPI, we will not tell you how to swing a golf club, right? What we do instead is we do the complete opposite. We all go, could we agree on the most fundamental biomechanics that people shouldn't do, right? So we go, okay, when you swing, should you move towards the golf ball during your swing? Coaches will say, no, you shouldn't do that. You lose space. Like in baseball, you get jammed up, you can't hit a inside pit. Okay, we agree you shouldn't do that. Should you start with your upper body first? And so you that's called over the top. Every coach says, no, you shouldn't do that either. Now, if I said, how should you start? That's not our philosophy. I don't. All we're saying is we agree on these certain fundamentals that we shouldn't see. So what we do is we go through and we interview for years, like 2-3 years, tons of coaches, and we get down to a point where we go, okay, we came up with these 15 things that every coach agrees with, right? So like we call it, like in golf, we have the Big 15, right? In baseball pitching, we have the Big 12, right? The Big 15 are the 15 most common characteristics that every coach on the planet that we talk to would say, yeah, of course you shouldn't do that, right? So once we show you, like, here's all the things you shouldn't do, people go, oh, now I know what to do. And I'm like, well, first of all, I didn't tell you what to do. I just told you shouldn't do these things, right? And then what we do is we say, what's interesting, a lot of people do these things, right? A lot of people do these things. We go, why? Why do people do these things that we all agree you shouldn't do? Well, one of the reasons people do things is because that's the only physical thing they can do. They don't have ability. So we said, is there a way for us to do a physical assessment to screen somebody and see that if they can't do this, they're probably going to do one of those 15 things, right? So to go back to your running, like if I was going to go after marathon or ultra marathon or something that matter, I would sit down instead of trying to figure out, okay, what's the best way to run? Like, I'd say, can we all agree on here's the things you shouldn't do, right? Maybe a coach gave them the wrong information. And if you can agree on all the things that you see people do wrong, you've got a potential to come up with a screen.
Well, and I agree. I mean, I teach, we basically have 7 parameters that come from all of the gait analysis research on, from the most detrimental to the least detrimental. But I think
can you do a physical screen and predict if they're going to do those?
For sure. I basically came up with a mishmash. And my thing is, I guess I'll kind of eat my words from before. I think what happens is, which I think this happens in all sports and why you guys are successful. So let me back up. I think coaches and trainers try to get people to run a certain way without seeing the physical limitation, which creates the problem, which in essence, now we have a non-implement sport, right? And the body is the thing. And yet we just kind of say, oh, we don't want to have overstriding or a tibial inclination angle of this much. And we don't look at, can their ankle even do that? And then we create a problem by trying to idealize the running. And I think that's the crux.
I'm going to date myself, but Patrick Swayze said, don't put baby in a box, right? We don't need that, right? If you say everybody's got to swing like this, I totally disagree. Yep.
Yeah. So, well, that answers that for the running, which again, I figured that would be the answer. My thing would be,
and by the way, I'm willing to learn. If I'm wrong, I'm all in.
No. I mean, when I pitched this to Brooks, I literally said, well, per Greg Rose story, Titleist want to sell more golf balls. I'm sure you want to sell more shoes. Like, let's go. I think the thing is, and maybe in golf, what would be your take on shoes get looked at as a fix or an implement to change running, right? More of a drop. Catalyzing, forward propulsion, more cushion, a carbon plate. So now the thing that you're selling is supposed to change the mechanics. If I change the mechanics, does it negate what shoe I wear? And I know that's maybe a harder question to answer, but like let's say Titleist now sells golf clubs for a specific type of swing. Well, does that change what you guys do?
I think maybe I'm going to think of this a little differently. Is I would say, based on your physical abilities, right? Let's say you've got somebody who's got great ankle mobility, and then you got somebody who's got horrible ankle mobility. Would you put them in a different shoe?
Probably.
Then the shoe matters, and the type of fitting matters, right? Based on their physical way. So I agree 1,000%, right? Like if somebody's got no mobility, I probably want a shoe that's as mobile as possible. Somebody's got no stability, I probably want a shoe that's stable, right? So I feel like people think of shoe fitting as in like, okay, size and last and volume over there. And I'm going, you and I are both going, how can we assist the human, right? So first thing I need to know is what the human can do, and then try and match a shoe to that. So I feel like it if like I think I'm going to take golf, right? Because we
Well,
obviously
FootJoy did this for a while, didn't they?
like I said, I'm going to take golf because we own FootJoy, right? So
Yeah.
we evaluate. We're big on shoe fitting with our players, and what we do, we actually I helped design a shoe called the M Project way back for FootJoy. It was the most mobile shoe in golf at one point, but we have the most stable shoe, right, all the way down to the most mobile shoe. We tried to create a suite of different ones because that's how we were fitting. We were basically, first of all, we would go in and we would evaluate their mobility, stability. We would look at the lower extremity for sure, and we would put them in 3 buckets: very mobile, very stable, a tweener somewhere in the middle, right? One of those three. And we had shoes that we had preferences. Like if somebody had no mobility, we had we called them the happy feet mobile shoes, trying to give them mobility. And if somebody had no stability, we had the platform stability shoes, and then just normal somewhere in the middle, right? Like a drag bike for us. And basically we would then go and we would try and figure out what's the best last. One of the things that people don't understand about shoes is that as we get older, most people's feet actually get smaller and wider. Like, if I say I'm an 11, and I try an 11 because I was 11 when I was 12 years old, and I just haven't tested it ever since. And I just go in and I say 11 and it feels tight. I usually ask for 11 and a half, where actually a 10 and a half wide is probably what you need. So people come in with the wrong size shoes, and the left foot and the right foot sometimes aren't the same size. I mean, there's so much to that I think is ignored in the world of professional sports, that when you get the right fit on there, they go, my God, like I can use the ground better. Like the ground reaction forces on force plates are different when you actually fit them properly.
Yeah. What would be your take? I didn't plan on asking this, but just because, again, I agree with matching, foot architecture and ability to the shoe during performance. What about in practice? Does it change with footwork because you have this whole, minimalist shoe movement to strengthen the foot? And we could also say, well, if you have a really rigid foot versus a very mobile foot, you could still use stability to train either one of those. Would you change what you're doing with that? I'm assuming yes.
Yeah, I mean, it depends on what the goal is, right?
Yeah.
I'm always like, in training, we try all kinds of stuff. And then in performance, we're going to go with what we think is going to perform the best right now.
Yeah.
Right.
How much, so you brought up the story during your talk also of asking Mark Blackburn if he had to pick one tool to use the rest of his life, it would basically be force plates.
Yeah.
Force plate treadmills have been huge. Bilateral force plate treadmills have been huge for gait analysis for, the past 2 decades, floor treadmills. How much has that changed what you do in terms of working with a golfer, in terms of working on their body, but also golf as a skill?
Force plates have changed the way I look at players and train players more than any device in the last 10 years, right? Like I said, I feel like force plates have done 2 things. Number one, they allow me to literally step inside my player's body and try and feel what it feels like to do what they do. Like, just think about it. Imagine if you had a sprinter and you're like, I can't figure it out, but can I just step in your body real quick and just run the race in your body? You'd be like, as a coach, you'd be like, oh, I didn't realize you were doing this, right?
Yeah.
I'm always like, I always want to step inside my athlete's body and feel like, hey, what are you doing? And before we used to look at 3D or 2D video, and it would show us like, okay, their hands are here at the top. So we'd put our hands there at the top and we go, okay, I think you're doing this. But not knowing that there's 400 different ways to put your hands there at the top, right? And how you put your hands over there can dramatically change the feel. And that's what we get from the force plates. It's how you move, right? I can see, are you pushing forward or to the side? Are you going vertical? Are you twisting? Are you torquing? Like, we can see all those things. And then the second piece, so first of all, it allows me to get a better understanding of what my athlete's doing. And then secondly, and probably the most important thing, is I started evaluating our exercises, right, and our drills. And I'm going, do they match what the athlete's doing from a force production on the ground? And I can tell you right now, Beau, half the stuff I used to give people, it wasn't even close. Right. And I'm like, we used to go like, I can't believe that doesn't transfer. Like, that seems like such a cool drill or transfer. And then we got on the first plane, and I'm like, now I know why it doesn't transfer. Actually, it's potentially negative. Like, it's completely different the way they're creating force. So now I went down this pathway about 3 years ago going, I got to take every exercise, get them on the force plates, and I can start mapping out the exercises. And I'm like, this is going to be amazing, right? So I started taking medicine ball drills and I'm going through, I remember I had one athlete and we went through like 30 drills and I was like, this is awesome. So I took the 30 drills and I'm like, all right, this one's more of a frontal plane torque. This one's more of a lateral. I was like, all right, we got to do some more. And I was like, you know what? Let me grab another athlete. Let me just make sure that that's what those, I got the next 30 exercises and he did them completely differently. And I was
Yeah.
like, oh, damn, okay, that was dumb. Like everybody doesn't do exercise the same either, right? But now I can at least see when I give somebody an exercise, are they doing it the way that they do it when they swing so that we get transferred? That's just a game changer.
Do you go that in depth with each player now of like if you're giving them correctives or something that you're putting them on the force plate to see if it's actually
Yeah,
getting what you want?
we've always done this under 3D just to make sure that they're sequenced, like
Yeah.
the way they're transferring it. But now I can see how they start their power to see if it's the same way, and then does it transfer through their body. I always feel like, man, anything you do on a regular basis throughout the day, you're just like, I'm just going to practice my backswing in my office, man, it better be perfect, right? So I'm like, we can measure that now to see if it's actually perfect, and we can go keep doing that. Or I can't tell how many players come in. I'm like, let me see the drills you've been working on, and I'm like, don't ever do that drill again. Like that's actually part of your problem.
Well, I thought the two best slides in your entire talk in Florida were just the bullet points of motor learning and then feedback of like summarizing, because that's and you could kind of tell within the crowd there, like that was, I wouldn't say mind blowing, but like there were people that maybe have never heard that, but also definitely weren't adhering to it just based on the questions and the pushback. And
Well,
um, I think it's very interesting. I mean, my one question there is, and this is just kind of a fun question, I guess. So you talked about basically using an aid, right? Some sort of device or something
guidance
for
device, yeah.
feedback.
Mhm.
So where does something like RNT fit into that? Because you were kind of bristling against like a feedback. So if I use, and you said there's a time and place for it for sure. The RNT, we're using a band, obviously, to direct traffic into the mistake. So how's that fit into that
Yeah,
whole?
RNT, the fancy name for that, we call it challenge feedback. There's facilitated feedback and challenge feedback. So any type of feedback, right, to me does one major thing, right? It helps the athlete do the motion properly, right? That does not mean they learn doing that, right? It helps them do the motion properly. Now, once you get them to do the motion properly, you can now start the motor learning process and teaching them how to learn how to do that and how to remember to do that. So guidance devices, I think, are great, like reactive neuromuscular training, RNT, to go, oh, that's what it feels like to do that properly? You go, yeah, that's what it feels like. Now, what does that feel like? Now you ask the athlete, and the athlete goes, oh man, well, so when you were pulling me to the right, I was trying to prevent myself. So as I turned, I felt more like in my groin where I usually feel on the outside of my hip. Perfect. Because as soon as you have that feel, we can take a feel. We can't take form. Form doesn't work. We can take a feel and we can create a motor pattern now, right? So it's like create this book on the shelf in your brain. And once you have that feel, we can go into all the research. It shows you how to do this, but now you need to be able to do it without the guidance device because no one's not going to be pulling on them in their golf swing. So they have to be able to reproduce that feel, but they needed to know what the feel felt like in the first place. That's where guidance devices come in. The problem is so many people just practice with guidance device and they never let them go. So they never really actually took the next step to see, could I do it without the guidance device? And that's so important. So I think the motor learning world for a while was like, get rid of guidance devices because it wasn't transferring. But I'm going, okay, just because it didn't transfer doesn't mean it's not a good device. Maybe we're just not using it properly, right? So anytime you do RNT, you do any of these things, you can do this with a patient and as a client. I think the RNT entire goal is to reproduce a normal pattern and give you the feel. Once you have that, get rid of it and try and reproduce it.
In your world, this probably isn't a huge issue because you're dealing with extremely high level athletes, and you even said you're playing above the pain line most of the time. So for somebody that's in clinical practice, whatever you want to call them, the loving term that I've actually heard come from the TPI world was a motor moron, whoever said it first. But let's say we have somebody that's not kinesthetically graced.
That's the norm, by the way.
You're right. So
Yeah.
now how much does that change? Obviously you have a high level athlete, like they may need like literally like 4 reps with some sort of RNT and I got it, and then you remove it versus somebody literally you think they got it, and then they come back in and it's abysmal
Well,
again. Like,
listen,
how do you?
we've all experienced that person where you do the RNC, it looks great. It's so different than what they normally do. And you go, can you feel that? And they go, I don't feel a difference. Right? That's a motor moral. You're like, dude, it's like the amount of movement is like reduced by 12 inches. And they're like, I just can't feel it. So if you have that person, in my personal opinion, you can't move on. You have to keep doing more guidance devices, more things, because until they can feel it, they're not going to change because
Yeah.
they tell the difference between the old pattern and new pattern. So I feel like this is probably, like I said, the norm is that usually you have to try 2, 3, 4, 5 different things until they go, oh no, that felt different. I can feel something there. And you go, no, where did you feel it? Right. And it's going to surprise you what comes out of their mouth. It doesn't matter as long as they can feel the difference. And then, like I said, take the RNT away and say, okay, show me what you were doing before, and now show me the new feel, and see if they can do it without it. If they can, then you can do without it. If they can't, we'll go right back to the guidance device.
I
Right?
think I saw the most people sit upright in their chair when you when you asked how we program motor learning drills at home. And, there were a couple answers, and then you're like, it's like if we did 10 minutes of, work with a bunch of variety, high conscious level, like participation. I don't think that happens. I think okay. So I think that was a great piece of information. Absolutely fantastic. Then you said, there is the strengthening side. Like, now we got to, imprint that pattern. We got it. You got to strengthen tissues, make people more resilient. Is there, just like you have helped people in SFMA level 2 determine, joint versus tissue, how do you help clinicians determine when can you make that jump? Okay, how do you know it's a proficient pattern, and now we can go into training it, in the gym setting?
Yeah. I think this is a coaching decision, right? So this is what Bill Belichick would have done with Tom Brady, making a coaching decision. You're doing with your patient, right? Going, number one, do I trust them to do this at home on their own, right? And then number two is it's at the point where I don't even have to say it anymore. They're just kind of doing it, right?
Yeah.
Or they'll say, I don't even feel it anymore. And you're like, let me check. And you're like, well, it's because actually now it looks kind of good. That's when I shift into, okay, hopefully, because our goal is for it to become automatic. I don't want you to
Right.
have to on it, right? So that we can just do strengthening on there. So to me, that's a game day coaching decision.
Okay. You also mentioned,
Pretty obvious, though. It's usually pretty obvious.
yeah, and again, I would say, but I think sometimes
Sometimes
you
it's
see
not.
one or two things. People perpetuate motor learning concepts, whether they're doing it right or wrong, through the entire rehab trial of care, or it's right to strengthening in the face of the motor plan not being idealized or as good as it could be,
Yeah.
or offloading the
Yeah,
sensitized tissue.
I think that's a good point too, is that, a lot of times you're like, oh, we got to build a new motor pattern, and you don't realize that they actually have the pattern already. They just built a bad one on top of it.
Yeah,
And most people, like within a minute or two, don't need motor learning. They just need repetitions now or strengthening, right? And again, like that doesn't surprise me either. Sometimes I'm like, oh, it seems like maybe if they say, I used to do that when I was 14, and then somebody told me, like, okay, then we're not building a new motor pattern. I just got to remind you.
yeah. You talked about, and I've heard you talk about it before, of normal aberrations of movement or normal dysfunctional non-painfuls with certain athletes, right? Whether it's a unilateral athlete. Do you think that those are, and let's just use golf as one, and then I want to kind of ask about running, but let's use,
Stuck in advantageous asymmetries type of thing.
that was my question. Like, are they advantageous, or are they just normal asymmetries?
Okay. I definitely believe in advantageous asymmetries for certain sports, right?
Okay.
Built on by countless hours of okay, um, if I take let's do Captain Obvious, a baseball pitcher, right? Their total arc should be normal, right?
Yeah.
But it better be shifted to external. Like they better have a 2-3, or I don't like 3-1s, but they should have a 2-3 on the FMS shoulder, or else we always we have a station at the NFL Combine, right? And if you know anything about football combines, the pre-combine training, people try and make the athletes perfect the combine scores, right? It's like, I want to get the best. So they're like, we're going to nail a 21 on the FMS, so we get all the data for the teams. And I can't tell you how many times teams have said to me, like, hey, I got this quarterback and they got a 21, and I'm going, quarterback got a 21, I wouldn't draft them. Like that is not normal for a quarterback. If you tell me their shoulders balanced, I'm like that either they're not throwing enough or somebody did the test wrong. That's messed up, right? So I feel like there are how you get these asymmetries is important, but I think there are to me I call it this. I hope this makes sense. Like in FMS, we call it the or okay, like let's say you want to win the Masters, we call it the jacket bracket. If you want to win the gold medal, we call it the medal bracket, right? If you're going to be you want to win the gold medal in table tennis, right? Pretty confident you need to be between a 15 and a 17 on the FMS. And I can show you how you need to be able to do that. Now, to keep you in that 15 to 17, there are certain advantageous asymmetries that we feel help you in the sport. Now, to stay there, you don't try and make these asymmetries in training, right? It's just you practice so much, it develops these.
Happens, yeah.
So we always say, like, your goal, here's the cool thing, for you and me, the guys in the pit crew, right? We're trying to balance it. Like, we should be treating you trying to balance it, but your volume of practice shouldn't let us win, right? So that if we got the good ratio of treatment to practice, you'll stay in that bracket, right? Now, if we treat you too much and you're not practicing enough, all of a sudden you'll start going above your bracket. Right. If you're practicing so much, but you're not getting enough treatment, you'll start to drop below your bracket. And keeping them in that bracket is quite the challenge. But that's kind of how I look at those advantageous asymmetries.
Yeah. Which I would 100% agree with that. And again, and I know would you say you have something like over 5 million data points within, is it multiple sports or just golf?
Multiple points. Whole limit. Yeah.
So when we look at running, the two big, this got into a big social media thing a couple weeks ago that, it's normal for runners not to be able to touch their toes, and then obviously a deep squat because of ankle mobility issues. So here's my question. Obviously that's normal amongst that population, but then you can very quickly look at data on not being able to touch your toes and the correlation to low back pain, even though people want to say there isn't one, there 100% is. So again, how do you reconcile, now you're working with a major pattern, like just a flexion pattern. Somebody were saying, hey, it's normal, you can't do it. And then you're like, well, man, there's all of this information saying that if you can't touch your toes, there's a much higher risk of low back pain. So again, I know we're trying to balance them, but because I know we're tuning athletes and you need some stiffness, especially depending on what sport you're playing. Like, is that just, again, game time decision? What's the phenotype of the person in front of you? Or are there certain things that you're like, God, I know that's advantageous, but like, could we get a better flexion pattern? You just control the end ranges better. Like, are there certain things you're like, we don't like that, even though it's normal in that population?
Yeah, normally, I'm trying to think in my mind. I said, well, normally they're advantageous asymmetries. Like, right toe touch is better than left toe touch.
Yeah, like a curve runner in 200, use the Usain Bolt. Yeah.
100%. Versus bilateral can't touch your toes, right? Those are usually not advantageous. There's not a lot of this, right? So, I again, like you just said, a curved runner, I could see one side potentially being stiffer than the other side, but in general, most professional athletes are way more mobile than non-professional athletes.
100. And that was my argument. If you look at the bell curve, professional marathoners are super mobile. I wouldn't think they were until you look at the data and you're like, oh, they can sit in a full deep squat and touch their toes. And
I mean, look at Olympic lifters. I mean, people think, in weights, I mean, they're probably the third most flexible athletes in the Olympics. They got to get under the bar. They don't get the bar with their head. So I think that people go, oh, they're tight. Compared to who? Compared to the most flexible person in that sport, or compared to normal humans? Because normal humans are the ones that are tight. These athletes are like, I'm like, and people say, oh, John Rahm, the PGA Tour, into the Live tournament. John Rahm, he's a big guy. He doesn't have a big backswing. He must be tight. I'm like, actually, he's one of the most flexible guys we that's just he learned to play from a short swing, right? That's all I learned, right? I'm like, a lot of these people who challenge us, I'm like, you need to test more professional athletes.
No, that's a really good point about the comparison, like population comparisons like that.
Yeah.
I was actually talking.
I hate it when they say, "Oh, really fast athletes have to have tension and have to be tight," and I'm like, now you're telling this kid who has no flexibility that he should be tight. Like, that is not what they're talking about. Like that's lack of mobility. They're talking about tissue tension. That is totally different.
Yeah, the ankle dorsiflexion debate within running is a huge, I think, misconstrued Like, I think you're hitting the nail on the head, and I think people just normalize things that
I
can
think
lead to injury.
things that are hard to produce, like if you find somebody who's got tight ankle dorsiflexion and you don't know your stuff, it can be very challenging for a medical practitioner to improve that. When they don't have the skills, most people don't go, I need to learn the skills. They go, it must not be that important.
Yeah,
I
yeah,
see that a lot. So don't,
normalize it.
yeah.
I was talking with a golfer in here the other day, which it's a different scenario when it's a, club golfer. He was like, basically he wanted to know why I thought he needed to increase the amount of rotation in his swing, right? Because he had basically a stability motor control dysfunction. And I was like, you don't want to play it in ranges and you're, all this stuff, trying to explain it to him. And he goes, well, is that what pro golfers do? So I just kind of had a question come to mind when you brought up John Rahm, right? So because I heard you say what force applied over longer times or more force applied is how you're going to get more distance out of the ball, basically.
Mm-hmm.
So if you have a John Rahm that has more in the bank in terms of range of motion, why not maximize it? And you're like, well, he's doing great, so don't change it. But is there ever like an injury prevention mechanism where you're like, well, he doesn't have to create as much force now if he can go further into it, as long as he's not running up against that, physiologic barrier?
Yeah, so John's a great example of this. I mean, John was born with club foot on his right foot.
Mm-hmm.
So his ankle is pretty much fused. I mean, he can't really use his ankle. And the more he rotates, the more he goes unstable on that backside, right?
Gotcha.
So he grew up playing high lie and these little short change direction sports. And in a way, I'm like, this is perfect, man. Like we're not taking you beyond your physical range of motions. Now you have them. You have the range of motions.
Mm-hmm.
So like we said, there's 3 ways to develop power, right? You apply more force, you move your hands faster, or you apply that force and velocity for more time.
Mm-hmm.
A longer backswing gives you more time to apply that force and velocity. But I'm like, John Rahm is like the size of you and me combined, but he's huge, right? But like he's got so much force and velocity, I don't even know if he needs more top. Like he doesn't. So if he took a bigger backswing, could he hit farther? The scary answer is he probably could. He doesn't need to. He's still one of the longest hitters out there. But I think what he's done is he's stayed inside his physical abilities.
Yeah. So you've created that barrier. Well, kind of the last 2 questions I ask everybody on this podcast, you can take it wherever you want, keep it in the professional realm if you want. But what is one thing that for a very long time or for a long time you held to be true that you completely changed your mind on? You're just like, oh, I shifted.
I think we talked about it. Force, man. Like
Yeah.
the force, I'm telling you, like there are, I throughout my career, there's countless examples. Like in SFMA, we talk about proprioception. We used to think everybody had proprioceptive problems. Now I think it's more mobility problems. But I think force has completely changed the way we look at players, to the point where I agree with Mark Blackburn. Like if I was only going to have one tool going forward, it'd be a force plate. And assuming that the drill looks good does not mean they're creating force the same way they do in their sport. Like that. To me, I'm like, wow, it looks perfect. They have to be doing it right. I just don't believe that anymore. So that's probably where I would go with that question.
Is the only proxy for that, like, because you said you're putting, athletes on force plates for exercises. So let's say we have a clinician or a golf coach that doesn't have force plates. Is there any proxy besides feel for making sure that, like, if it looks good, because like you said, form isn't the thing we want to fall back on.
Yeah, I mean, I think, it's kind of like, I don't have an MRI machine, but I've learned a lot from MRIs, right?
Mm-hmm.
So force plates the same way. Like, I think don't be like, I don't have it, so I can't do this. No, we've learned so much from it that I think you said it though. If you're trying to get something to transfer, please don't look at like, oh, that looks like a golf swing, so that exercise must work, right? I don't care if it looks golfy. What's more important is, does it feel like your golf swing, right? If it feels like your golf swing, we're probably getting some benefits. If the exercise feels totally different than when you're doing the sport, I'm not sure if we're using our time, let's say maximizing our practice.
I remember Charlie Weingroff's talk at World Golf Fitness Summit. I don't know what year it was. Golfish. That everything, if it looked golfish, oh, that's great, and trying to get away from that. Well, real quick, you had mentioned that another one was maybe the proprioception versus now. Can you just touch on that for a second?
Yeah. So I think how old are you, Beau?
40.
Okay, so I've got almost 15 years on you. So when I was going through school, and maybe it's the same when you were going through school, everybody had a proprioceptive problem.
It was pretty much the same.
Yeah. Well, that's kind of what we were taught. Like everybody first started. And then I started looking at a lot of the, I'm thinking golf, we got to have smooth balance. And we started looking at all these unstable surfaces. You have the Eric's pads and you have the bounty and all that stuff. And the research was coming out really clear that it was very poor transfer. We're like, this is crazy. Like, you'd think that if we work on unstable surfaces, it would transfer really well. But I wasn't seeing the transfer either. And the research was saying it doesn't transfer. Now, when we started SFMA, we got to single leg stance, and I told you we had a bunch of smart people there. I grabbed Dr. Mike Voigt from Belmont Therapy. His doctorate was in proprioception. I said, Mike, you are going to help me do single leg stance. And Mike, with his southern accent, was like, no problem, Greg. He goes, we'll knock this out first. This will be easy. It took us 3 years to do that. It was like, I keep blaming it on him. I say, Mike, you must be slow. But our paradigm was wrong. We felt like everybody, so we started with proprioception. We tried to do proprioception, but now it's like so Captain Obvious, right? Like you said, a fundamental switch. It's, how do mechanoreceptors, proprioceptors, how do they work, right? When a joint moves, it stimulates the mechanoreceptor, and pressure changes and can stimulate this, right? So to say when you sprain your ankle, oh, you damage your proprioceptors, now you have no stability. It makes way more sense than when you sprain your ankle and you lost mobility and you're not stimulating it anymore. Because what we found now is that if I just give you your mobility back, it's amazing. The proprioceptors are working now, right? Like, I don't think they were ever damaged. It's just they weren't getting the proper input, right? So we flipped our entire thought. We were like you said, rule out by exception. We said, let's check first to see, make sure there's not a vestibular problem, right? And then if there's no vestibular problem, let's just make sure that you've got the appropriate core control mobility. Let's just make sure you've got ankle mobility. Because if you don't have those, let's just break that loose first and see if all of a sudden your balance improves. Because 95% of people improve now when you do that, right? But if your vestibular is good, you don't have any core, spine stability, or ankle mobility problems, then we're going to go, okay, then you probably do have proprioceptive problems. But based on our millions of data right now, that's less than 6% of the population.
Yeah.
I going through school, I thought it was 96% of the population.
You needed like 8 Bosu balls and blindfolds and everything else.
Yeah.
Well, the flip side of that question is, what is something that you hold to be true, or you're just like, I think this is the way it is, but there's no data to support it yet? And I'm gonna hold you to a different candle, that you can't use something that you have data on from TPI that hasn't been released.
Oh man, let me think about that. Okay, big break theory. Now this is something Tom House and I. Tom House, one of the best coaches in the baseball and football world. We have a philosophy we call the big break theory, which is that you will only accelerate as fast as your brakes can decelerate you, right? So we're going, like if I'm in a car, I don't want to go so fast where my brakes don't work anymore because I'm in trouble. So we feel like the body puts an internal governor on you. So this is why we're really adamant, and there's tons of people that call us wrong. And again, the evidence we have, I say no evidence. I think the evidence is what's the word, non-conclusive yet. But people say, should you waste time training the opposite side of the body, right? We always say, I feel like it's a huge value to train the opposite side, not only because the biggest, fastest athletes in the world have some type of history of non-dominant side training. Like, it's scary, the volume on there. But I feel like the best way to train your brakes is to go explosive in the non-dominant side, right? So we do lots of non-dominant side. Like for your sprinters, I would have them run backwards.
Mm-hmm.
Do you do that with your guys now?
Well, yeah, and I mean, a lot of this, you're a big mentor to me, even though, this first time we've kind of talked privately, but I still remember, I think you brought the example up of who are the fastest people in the NFL. It's usually cornerbacks. Now, is that because they run backwards, or just that's the position they fell into? Nobody will ever know, but it's a good correlation to make,
Yeah. Yeah. It's like, if I go through like, the fastest swingers on the PGA Tour, like they were left-handed in this sport, and now they compete in this sport, a long drive. If I go to baseball, like there's always this like, man, I didn't think about it, but yeah, I did this when I was young. I did this left-handed or blah, 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 and now I do this. like I know coaches now, like in baseball and softball, that if you're a right-handed thrower and a left-handed hitter, they'll draft you. If not, they won't even draft you because the data is so overwhelming that, but no one in the research can prove that that's a, and there's some very, very smart people that say it's BS, but I can tell you right now, every one of my athletes is trained on dominant side.
Well, and I think if you take it out of rotary sports, though, if you look at, Trent Nestler, I guess he's probably the biggest influence on ACL, research that we probably have. I mean, looking at how people decelerate, right? Rolling through the ankle instead of breaking on the toes, but also like just how they decelerate.
Yeah.
And I mean, that's probably, it's one of the best, like, return to play criteria, but also risk assessments you can do for ACL.
Yeah.
So I think there is a lot of evidence in that realm.
Yeah. Yeah. I think a lot of people will tell you it's inconclusive right now on the big break theory, but I'm
right.
doing it no matter what. To answer your question.
And again, you don't have to obviously release any, clandestine secrets, but is there anything you've always kind of said if you come to a TPI or SFMA seminar and something's not new, that's kind of on you guys. So what's on the horizon? What's coming out in the next few years? Anything big?
I'll tell you something about that. I was pretty excited about it. We had a very, very smart gentleman from the Johns Hopkins organization come to one of our SFMAs, and one of the challenges why we have not put wrist and hand in the SFMA yet is we can come up with a top tier. I think he showed me a top tier for wrist that might work. So we still don't have foot, wrist, and TMJ, and we've been working on those, and it's the top tier that's the limiting piece here. It sounds weird, but that's for another podcast. But I think you might see a wrist breakout in top tier coming for SMA at some point. I told you I'm hoping that we'll be launching a couple other sports, quarterback certification, and then we're working on all of our level 2s in baseball and softball now too. And then I would say, our tools, our apps, are the things that complement our is something that we've been spending a lot of time on. But I love, like what you said, running. Like if you want to take a running one to the world, dude, just call me. I'm in. Like
Yep.
I love doing new sports and doing that stuff. Everybody calls me the juice extractor. You give me the 20 smartest people in running, we will extract the juice from their brain and come up with experience.
Well, and I asked the question during your talk because you said, two of the big pieces is hand, TMJ, and then foot. And wrist for gymnastics, which is, what my wife specializes in, is a nightmare. I mean, that's like one of the biggest plagues in gymnastics. And I know in golf, it's also up there for kind of a killer of careers. I know you said you might have one for wrist. Are you guys actively working on foot and ankle a little bit more, or is that something that's just kind of back burner?
It's kind of weird. It's like we know how to break out the foot. It's
Yeah.
more of if I said, what's the top tier movement that identifies altered foot mechanics?
Gotcha.
That's where it gets complicated because you're like, is there one movement that I can do to see if there's all things in the wrist and
Yeah.
foot or in the TMJ? And I'm like, I think TMJ might be a little easier, but the foot and hand have been challenging. But like I said, a very smart person showed me something a couple months ago, and I was like, man, that might be it right
Yeah.
there. Yeah, it's weird. Like I said, we have breakouts. So I know, like, your foot's a problem. I think I know how to break out your foot,
Mhm.
but I'd like to have a top tier to make it fit in the model. You know what I mean?
Well, hey, I'm always excited, and I keep tabs on you guys, obviously, and
Cool.
it's been a few years since I've been to a TPI or SMA, so I'll make sure I head to one if it comes around our area, or we'll host one here in Nashville, Birmingham soon. But before we jump off, any last?
Are you in Nashville or Birmingham? Where are you at?
I'm in Birmingham, but we just started an education company where we're hosting in Nashville just because it's more fun. People want to go to Nashville. It's easier to fly into the Birmingham. So we're doing a lot more in there.
For me here in Little Rock.
Yeah. We're actually heading away from you, but we'll be heading up towards, we go through Arkansas on the way up to Missouri, which I didn't realize is like fly fishing mecca in North Arkansas.
Well, big time. It's like, have you been there?
I saw a trout. Well, yeah, I saw a trout on the water tower wherever I was. And I was like, oh, and then I started looking into it, and yeah, it's amazing.
Beautiful area. Cool. Awesome. Well, thanks for having me, Bill. Appreciate it.
Absolutely, Greg. Thank you so much. And hopefully I'll see you again soon.
Thank you for tuning in. Please subscribe via YouTube, Apple Podcasts, or Spotify. If you like the message, please share it. We appreciate it. Thank you.